Ozempic, Wegovy, Manjaro. Let's kiki about it. It seems like everyone wants to put their 2 cents in about weight loss injectables, and most of it is negative. And that's not surprising because we know that outrage is the most viral type of clickbait, right? But when it comes to Ozempic and these weight loss injectables, it seems like a lot of this anger is regurgitated fake news. And honestly, I am sick of it, and that's why I'm having this live today. Because I want to clear the air about what are the truths about Ozempic and these other weight loss injectables and what's just BS. So I will be bringing up Dr. Rocio Salas. She is a double board certified endocrinologist in NYC. She specializes in obesity, diabetes, and thyroid disorders. And she's going to be here to talk about these drugs and answer our questions. Now, I am someone who has been on weight loss injectables since December, and it has changed my life for the better, and I'm not ashamed of it. But so many people come into my DMs saying that they're hiding the fact that they're using this medicine because they're ashamed to talk about it, and even though it's literally saving their life, and that's not okay. So I'm gonna bring up Dr. Salas. Hi, Dr. Salas.
Hi, how are you?
I want to make sure I'm pronouncing your name right. Dr. Rocio Salas, right?
Yes, correct, Rocio Salas.
Okay, perfect. And I want to disclose to everyone, Dr. Salas is not my doctor. She hasn't treated me. I actually found her because New York Magazine had an article about Ozempic, and Dr. Salas was in the comment section, the only one that was really in there educating, providing answers, and commenting actual knowledge about these drugs. And I was like, I need to have you on my live because I think there's so much misinformation around these drugs. So I think a lot of people hear the word Ozempic. Everyone's talking about it, right? So I just think for anyone who doesn't know, can you just give us a little bit, because people think it's a new drug, and I want you to just tell us a little bit about the background, the history of this drug, because it's not something new.
Yes, exactly. So the Ozempic belongs to a class of medication. They're called incretins. And the first incretin was FDA approved for diabetes back in 2005. So we have this class of drugs for almost 20 years. So they're not new drugs. What's happened is that through time, they just became a little bit more user-friendly for patients. Our first incretin back in 2005, it was a daily injection, a twice-a-day daily injection that patients had to do 30 minutes before their breakfast and 30 minutes before their dinner. And then in 2010, Victoza came as a once-a-day injection only. And then 2017, Ozempic came as a once-a-week injection now. So the Ozempic on its own in 2017 was FDA approved, but this class of drug that they work all the same are since 2005.
Okay, and so it started becoming used as a weight loss drug because it started as a diabetes medication, and then they noticed that patients were starting to lose weight. So it was around 2017 that they said, let's make this specifically for weight loss.
No, in 2012. It's FDA for weight loss. So in liraglutide, which is Victoza, the once-a-day injection, in 2010 came approved for type 2 diabetes. But as you said, even when I came out of my fellowship, we were prescribing it to patients because it works great for diabetes. And then patients were coming back with better glucose control and weight loss. And because this drug doesn't cause hypoglycemia, it's not insulin, then we started using it off-label in people without diabetes for weight loss. And in 2012, FDA approval for weight loss, and it was branded as Saxenda, which I'm sure a lot of people have heard, right? So since 2012, this drug is FDA approved for weight loss.
And you mentioned the glucose, because some people were worried about, like, if you aren't using this, if you're using this specifically for weight loss, how does that affect your glucose? Like, does that
It does not touch it. It does not touch it. So this type of drugs are their effect are glucose dependent, meaning that the person actually has to have diabetes or an abnormally high sugar to work as a diabetes drug. But if your sugar is completely normal, like in a non-diabetic, it passes your pancreas on the side. It doesn't touch your pancreas.
And so how drug work for weight loss? I mean, I know that when I'm on it, it basically, I feel full. I'm not thinking about food all the time. I don't know, like, how exactly is it, what is it doing in my body?
So I like to explain to my patients that this medication, it targets the two ways that we humans eat. We eat for hunger, which is a physiological, and then we eat for reward, right? Which is more like a comfort or emotional or some sort of reward. So for the physiological part of hunger, what it does, this medication, it increases your satiety hormones when you start eating. So you get fuller with smaller portions of food, and it decreases or suppresses your hunger hormones in between meals. So that's taking care of the physiological hunger part of eating. But we have receptors in our brain for this hormone in the hedonistic eating or drinking area in our brain. And it just takes away any reward or anticipatory reward from certain food or even alcohol, which is being studied now for alcohol abuse, right?
Oh, wow.
Basically, the patient, when they're on this drug, is you reach for it, what you used to feel as a comfort before. For some, maybe wine, for some, maybe sweets, carbs, and then you're not getting that reward anymore back. So you stop. So that's how this medication works for regards to weight loss.
Got it. Now, one of the biggest controversies out there, and one of the talking points that people love to say over and over in the comment section is, you're taking this drug away from diabetics. Is that true?
It's not true. And again, since 2012, we have the weight loss version independent of diabetes in patients, right? So it's not. And also, we have to think of, yes, this medication was designed initially for diabetes, but even Viagra was designed for something else and it ended up being used for erectile dysfunction, right? So there's many drugs that we have out there that were designed for one thing and they're being used for something else. So same with this drug. And I really don't think it's a matter of who deserves the medication more, right? People with diabetes or people with obesity. I think everybody deserves it and everybody will benefit from this drug, right? And we just have to remember numbers, statistics. There's double the amount of people with obesity in the US than with type 2 diabetes. And if we treat obesity, we're going to prevent diabetes. I predict that we're going to have so much less type 2 diabetes in the future because for the first time, we're actually treating what was causing all this complication, not just type 2 diabetes, hypertension, hypercholesterolemia, osteoarthritis, more than 30 cancers related to obesity, such as breast cancer, prostate cancer, stomach cancer, colon cancer, right? So we, as a medical system, we got comfortable treating all the complications of obesity because we didn't have treatment. But for the first time, we actually have treatment. And that's a really problem that we shame people for being on this medication because they're stealing medication from other patients. For the first time, we have something that we can offer patients with obesity that actually works. And it really breaks my heart that we're shaming them of using this medication. And I have patients in my practice that they come and tell me, oh, I feel guilty. I'm seeing all of this in social media. I'm embarrassed to say that I'm on this drug. It's like, we cannot give patients a break, right? We cannot give patients a break.
Agreed. Like I was telling them earlier, there's so many people in my DMs when I talk about this that say, like, I'm on it, but I don't want to tell anyone. And I think, like, I want to repeat that statistic you said, that there are double the amount of people who are obese than there are with diabetes. And that's like, for some reason, people don't see obesity as like a chronic condition in the same way as diabetes, but it is.
And that's something that is the bias, right? And I think we as a society, and very wrongfully, we associate weight loss as something external and superficial, right? And that's why people, oh, you're taking a medication to lose weight. How can you take a medication with side effects that's going to, but weight loss is very complex. It's not just what we're seeing outside, right? We're improving your metabolic health. We're decreasing your chances and your risk for other complications. I mean, many patients come with a long list of medications, and through weight loss, that medication shrinks. I always tell my patients, as we're going to shrink your waist, we're going to shrink your medication list. And ideally, we're preventing a lot of comorbidities from that come with obesity.
Now, a lot of people are in the comment section just talking about like Ozempic versus Mounjaro versus Wegovy. Can you just explain a little bit about the differences between like those three specifically?
So Ozempic and Wegovy is exactly the same drug. It's semaglutide. It's the same molecule made by the same pharmaceutical, which is Novo Nordisk. Ozempic is branded for type 2 diabetes. We just have to see it as an external brand. Ozempic is a brand for type 2 diabetes, and Wegovy, is branded for weight loss, independent of diabetes, right? So when somebody comes to the office and don't have diabetes, but they have obesity or are overweight and they benefit from the medication, then we prescribe Wegovy. But it's the same drug. And if somebody comes with type 2 diabetes and obesity, we prescribe Ozempic. It's just morely for insurance coverage. That one is branded for diabetes and one is branded for obesity. Now, Mounjaro is our newest incretin. I like to say it's our iPhone 14 of the drugs, right? It's like our newer, improved version of it that they fix all the bugs. So with Mounjaro, less side effects, less nausea. That's one of the most common side effects with semaglutide. Less constipation. I would say less gastric side effects.
Okay.
The reflux, nausea, constipation that we see with Ozempic or Wegovy, we're not seeing that with Mounjaro. And the clinical and the research and in clinical, we're seeing double the weight loss. Okay. So it is stronger for weight loss because semaglutide is one incretin, which is GLP-1. Tirzepatide, which is Mounjaro, it's two incretins, GLP-1 and GIP. So it's working in two different pathways versus semaglutide. Now, Mounjaro currently is only FDA approved for type 2 diabetes, but summer of this year, Eli Lilly is saying that they're gonna probably come with a branded version for weight loss.
Got it.
And like we could use this medication off label, right? Unfortunately, I mean, it's a very high cost drug, but if somebody will wanna pay for the medication, then we can prescribe Mounjaro, right? But if we want to go through insurance coverage, then it would have to be for somebody who has type 2 diabetes.
Okay. And you make a lot of really informative videos. And if you aren't already following Dr. Salas, follow her. I think it's New York Endocrinology. Is that you're at? Follow, you do TikToks, you do videos. And, one of the things you talk about and people ask, how do I use this long term and what happens when I get off of it? Now, I know I've heard long term, like this is good for long term use. There aren't any side effects. Is there any, you also though talk about, you do believe that when you get off of it, there is a chance of gaining this weight back.
So we have to think, and going back to the concept of obesity, right? Obesity is not a lifestyle disease, right? It's a chronic multifactorial disease, right? And when we say chronic, lifestyle is one part, genetics is a huge part. So if it runs in the family, hormonal changes, PCOS, hyperinsulinemia, menopause, perimenopause, aging, and then environmental factors. And environmentals could be work, stress, lack of sleep, what we're exposed. So if you think about it, there's only one piece of the puzzle that the patient has control of it, right? Everything else, the patient unfortunately doesn't have control. So with the medication, we're not curing all the other factors, we're controlling it. If we stop the drug, the genetic factors will still be there, the hormonal changes will still be there, aging will still be there, and environmental factors will still be there. The only thing the patient can modify is the lifestyle, and that's not sustainable long term, right? That's why we see all the failing and regain with diets and extreme diets. So with the medication, we have to think about obesity as we think of type 2 diabetes. Whenever we put a patient on medication for diabetes, I don't remember being asked, am I going to be off the medication once my sugar is normal, right? We assume and we've learned to accept that those are chronic diseases that require long-term care, that while they're on the drug, their blood pressure will be better, their glucose will be better, their cholesterol will be better. But the moment we stop, the numbers will go up. Same concept with obesity. Now, is it forever and ever until death do us part? It's very hard to say, but for the long term, yes, it should be used for the weight loss and the weight loss maintenance. And I always say to my patients, is that we should put it a positive connotation on the long term, because also for the first time, we have something that can help you maintain the weight loss. And that's what differentiates the medical treatment from all those extreme diets, right? That they take you to the goal, but then you're on your own to maintain it. Well, now it doesn't. What changes may change the dose of the medication, right? So maybe you reach maximum doses to reach your goal, but for maintenance, you're gonna require the smallest dose possible.
And that's what I find so interesting, because it's, we watch a show like Biggest Loser, and they're doing diet and exercise, which people tell you that is the singular way that you're supposed to be doing it. If you don't do it that way, you're not doing it the right way. But Biggest Loser, those aren't sustainable ways to eat. Those aren't sustainable ways to work out. And those people also gain weight when they get out of that because it's not sustainable. And what I will say is, I've only been on this since December. And what I like is that people say, just change your habits. Well, I am, because what I am learning is like what it feels like to be full, what it feels like not to just eat out of like boredom and comfort, which is what I was so used to doing. And the more I do that every day, I just know that like in 6 months, I'll be able to sit in front of a TV and not just automatically grab a snack because I've been doing it for so long. And that's always been my problem, right?
I mean, I have grown men in my practice cry that for the first time in their life, their their life doesn't revolve around that plate in front of them, right? That if you think about it, 3 times a day you're eating, 3 times a day you're thinking about how is this going to impact my weight? Am I, you know? And for the first time, you feel free. The medication takes the driver's seat, right? And it changes your behavior with food.
I totally agree. I was talking to my friend about this the other day because it's like, what other addiction do you know where it's like you need it to sustain? I have to eat and drink to live. And so I'm always focused on food. And before it was like I could be eating and thinking about what am I going to be eating for the rest of the day? And I agree, for the first time, I'm not thinking about those things. Now, one thing that I keep seeing, I'll see it sometimes pop up in IG, and for people who aren't able to get these medications covered by insurance, they're going to like these medical spas and getting these compounds. Like, do you know much about like these sort of compounds that people are getting?
No, I mean, this formulas still have patent for a while before they become generic, right? So first is the question, how are they compounding these drugs? How are they getting their patent? I mean, these formulas still have a patent. And compounded pharmacies, compounded medications, they're not regulated, right? We really don't know what it's on them. And in regards to efficacy, so we don't know if you're going to actually lose weight, and then risks and side effects, right? I don't recommend it. I don't prescribe compounded medications in general, even hormone, because it's just not regulated as well as FDA-approved medications.
Okay. I'm just going to some of the questions that people had that they had sent in earlier today. I think we answered a lot of them, but I'm just looking at some of these. Some people ask questions like, okay, with these medications, it seems to curb your appetite, but what if you are doing weightlifting, which requires more calories? How do you manage
so I'm
that?
glad that the weightlifting came into discussion. So one of the things that, and again, this goes by you going to an obesity board certified physician, because otherwise I feel like we're going to create a little bit of damage if we're giving them vicariously and not looking in weight loss as a more complex than just looking at the pounds in the scale going down, right? So what I see is it could be a lot of muscle loss with this medication. And it is not the medication itself that is causing the muscle loss, it's the hypocaloric diet that the medication puts you on, right? You're eating less, you're consuming less food, you're consuming less protein, so you can lose muscle. So the majority of patients with obesity or overweight, or even a lot of patients with normal BMI, they have higher body fat than muscle mass to begin with, right? And what we for what we consider for metabolic health is the opposite, more muscle than body fat. So if a patient starts with these medications and they already have higher body fat than muscle, and they lose body fat, they lose muscle, so they may be 100 pounds less, but they still will have more body fat than muscle. So key when starting this medication is a discussion about preserving muscle mass while you start losing weight. Otherwise, we're going to make a lot of people the skinny fat that they have. Their weight looks normal, their BMI is normal, but it's because they lost 20 pounds of muscle and 30 of body fat, right? So that's not healthy either. So resistance training is key when starting this medication. I would say, yes, definitely, you cannot weight lift 2 hours, 5 days a week when you're eating 1,000 calories a day, right? But twice a week, weightlifting is more than enough to maintain muscle. We're not trying to build muscle, but at least preserve muscle. And then increasing your protein intake in your diet is going to be key. Those two things to maintain muscle. So yes, you can weight lift, you can exercise, and you should, to maintain and preserve muscle.
Got it. Now, if someone is interested in looking into this, like what's the first step do they do? That they find an endocrinologist like you? Do they find like a specific type of
So
doctor?
ideally, an obesity board certified physician. I mean, we endocrinologists, we are the ones that deal with metabolism. But even me as an endocrinologist, I didn't get all this proper training that I learned as an obesity board certified physician in regards to obesity. So ideally, if you can find an obesity board certified physician, it will be your best bet to get somebody who has a lot of expertise with this medication. People can go to the abom.org, which is the American Board of Obesity Medicine.org, the website, and you can find physicians that are board certified in obesity and put your zip code, your state, your city, and then it gives you a list of who's board certified in obesity medicine. And then your second bet will be an endocrinologist, or ideally an endocrinologist that's board certified in obesity medicine, like me.
Now, do you see, I mean, you just said that like Mounjaro is probably going to like, you know, come up with this new like branded just for weight loss. And like, do you see the future of these weight loss injectables moving in a positive way, even though we're seeing so much negative, just like online chatter about it? Or do you think that's just a small percentage of people?
That I think, I mean, there's many more medications coming out. This is just the tip of, I mean, this is just the beginning. I mean, obesity medicine, this obesity medicine was the specialty that most physicians applied last year.
Oh, wow.
So, and that's great. We need, I mean,
Yeah.
we really need, we're not going to lack patients. We're never going to fight for patients, unfortunately, right? But I feel that first we have to understand weight loss as something for health and not as something external. I think once, because then when that happens, we're going to accept treatment, right? Because if we're just thinking of something external, then it's very difficult to justify being on a medication, an injection that you have to do once a week, right? But that's not the reason that we're doing it. We're doing it for your metabolic health. So I think the first step is to accept obesity as a disease. And once that happens, then we're going to embrace the treatment. And once that happens, we're going to prevent so many comorbidities, so many chronic diseases that we've been used to treating now and seeing.
And that's the part I feel like I don't know why people can't make that connection of, you know, long term, the money that's going to be spent if I am in worse health because of like complications from diabetes and other things versus, yeah, let's use the insurance money now. Let's put the money towards like getting me in a healthier place so that long term I live longer. Look, let's say I had to be on this drug forever. The insurance companies, I mean, the pharmaceutical companies, okay, they're happier because I'm living longer. They're getting more money out of me because I'm living longer term. I mean, let's be real. I mean, everyone's doing this for profit, but it's also benefiting me. I get to live a longer life, and there's no side effects. It's not like I have to, when I come off of it, I don't have to do any sort of weaning off. It's not like there's really any side effects from me stopping, is there?
It's not a negative in health. It's not going to take you to the hospital if you stop the medication abruptly. But I always recommend that as we gradually go up, we gradually go down. Because what's going to happen, let's say you're on 2.0 milligrams of Ozempic or 15 milligrams of Mounjaro, which is the highest doses, one of the highest doses, that is suppressing your appetite, and then suddenly you go from 0 appetite to 10, it's going to feel like 100, right? So that's why many people say, when I stop it, my hunger was even worse at the beginning. Well, no, your perspective to the hunger changed, right? It's probably not as high as it was prior to the drugs, but it's higher than when you were on the medication, right? So ideally, is to titrate the medication down as slowly as it went up, so you allow the patient to start to feel comfortable with eating a little bit more.
And the last thing I want to talk about, because I'm actually sick of hearing this term, is this Ozempic phase. People keep talking about like how people, when you're on this medication, you're going to have to choose between your beauty and like the weight. I don't believe that for a second. I do know that as I lose weight, yes, will my face get thinner? Of course it will. But Ozempic face, like why are people saying there's Ozempic face?
Well, I mean, I think right now it's Ozempic everything, right? Ozempic face, Ozempic body, Ozempic diet, Ozempic Hollywood, Ozempic drug. I mean, it's just Ozempic got the head of it, right? But it's a weight loss that is causing, and it's the rapid weight loss, right? So that's why we do not promote rapid weight loss. If you're losing 5 pounds per week, you're losing muscle. I can guarantee that you're losing muscle, and you're going to lose elasticity of your skin. You're dehydrated because you're losing so much weight. So it's dehydration, it's lack of protein in the diet, and rapid weight loss. So it can be prevented. It doesn't have to be like, okay, you're going to lose weight, but you're going to end up with this face. And it's just not the face. I always say it's not an Ozempic face. It's an Ozempic, it could be an Ozempic body, right? Because it's your skin. So keys is not rapid weight loss, hydration to maintain your skin plump, high protein in your diet. You need protein to make collagen and elastin, and then the weightlifting specifically for the body, right? So muscle will come and fill those gaps from the fat loss, right?
Yeah.
So those are the things to prevent Ozempic face, Ozempic body, but in reality is weight loss itself. I mean, there's nothing in the molecule of Ozempic that is actually causing the Ozempic face. It's the weight loss. It's as a result of the weight loss from the medication.
Well, thank you, Dr. Salas. I think you answered so many of our questions. Everyone, go follow Dr. Salas, and she does a lot of videos, really informative. And I'm of course going to keep this series going. I'm going to be talking about this a lot more because I'm going to be on my journey for a while. But thank you again, and maybe we'll talk again soon.
Yes, let's do it.
Thanks.
Have a good night.
Good night. Bye.